Hello again. Well, now on EASD TV, we're going to have another of our future sessions. And I'm pleased to welcome back to our studio Matthias Blüher from Leipzig University and also Anette Ziegler from the Helmholtz in Munich. And the session that you did together was Metabolic Medicine in 2030. So, Anette, I imagine you covered type 1. Where are we going to be in 2030?
I think the future for type 1 diabetes is prevention or delay of metabolic disease. And I think there are three areas that are really important. The one is a paradigm change that we have in the diagnosis of the disease. We now diagnose type 1 diabetes in its pre-symptomatic stage early. And this actually gives us the possibility to also intervene earlier. And this is kind of the second paradigm change that we have now. One medication that is approved in the States, teplizumab, a monoclonal anti-CD3 antibody that can delay the clinical onset, the metabolic onset of that disease. And the third part, I think, will be an important part in the future, is still more experimental, is the prevention of autoimmunity. So the intervention very, very early in life after birth to stop the whole autoimmune process.
I noticed that in Diabetologia recently, there was a report about a new vaccine in phase 1 trials against Coxsackie-B virus. And that, I think, is the main trigger, isn't it, of type 1?
Yes and no. I think viruses are important for the very early initiation of the disease, particularly in young children. We are not sure yet whether they play an important role also later on in adolescence and adulthood. And it's also probably not only Coxsackie, because we could actually show recently that the coronavirus, COVID, also seemed to increase the risk to develop islet autoimmunity. So, and the Coxsackie infections actually decreased significantly during the pandemic. So I think there are several viruses, and this is why we actually just initiated a trial with a vaccine against COVID-19 in the very young children from age 6 months.
Yes, because that's increasingly where we're going, isn't it? Vaccination of babies against a much broader spectrum of viral activity. So let me turn down to you, Matthias. Type 2, where are we going to be, and what were your takeaways?
I hope and I believe that when we will meet the next time, or in 10 years from now, we will have much more pharmacotherapies for the treatment of type 2 diabetes, but also obesity. We are talking about baseline treatment, for instance, with semaglutide or tirzepatide, that by then, as kind of the standard therapy, maybe with or without metformin. We will talk about triple agonists of the incretin system. We can then treat patients with oral incretin small molecules, maybe, that are easy to produce. We are talking about an etiology-based treatment of patients with type 2 diabetes in the future. Personalized medicine, maybe also a reduction in metabolic and bariatric surgery because of these new pharmacotherapies. Will we be able to treat to target? I'm afraid we will still have work to do. So it still requires a continuous effort, because it's a relapsing chronic disease which requires escalation of treatment approaches that may include even metabolic surgery in the future. But I think we will be in a much better situation in the next 10 years.
So I'm going to throw something at you, Matthias. How about the new drugs that we've been seeing to be so successful and have so many different impacts beyond glycemic control? Are they going to be the new statins by 2030?
That's a very good question. I think that the first step will be that we define type 2 diabetes, obesity, prediabetes much better, and not only based on crude parameters such as body mass index for obesity or HbA1c or other glucose parameters for type 2 diabetes. We know that these diseases are metabolic diseases that are much more complex, affect different organ systems and health, cardiometabolic health. So I wish for a more sophisticated definition of this complex disease, which may include parameters of lipid metabolism, of fatty liver disease, quality of life, maybe fat distribution, adipose tissue function, and other things, rather than taking only HbA1c and BMI.
Now I'm going to ask you a really provocative question. Are you ready for this, Matthias?
I hope.
So these new incretin-based therapies, which said they have all these other effects. Do you think that they will be much cheaper, and not just the new statins, but they will have far less stigma attached to them? And the most important thing of all, will we know by 2030 how they actually work? Because it seems to me that every diabetologist I've talked to at this meeting says, ooh, it might be just the weight loss, ooh, it might be inflammation, and then they go, ooh, but it might be something else. Will we know?
I'm very optimistic that we can tackle in 10 years the mechanisms associated with the treatment of incretin-based therapies, more than we know by now. Although I think we are close to know how incretin-based therapies work. I mean, we know that glucose-stimulated insulin secretion could be improved. We know that GLP-1, that GIP, glucagon, have effects on the regulation of appetite, satiety, locomotor activity, maybe an energy expenditure. So we are close to a better understanding. The first part of the question, I think it's more like a look into the uncertainty. Of course, it depends on the payers, on other stakeholders, but from the experience with, you mentioned statins, we can expect that these medications will become much more affordable, also due to IP-related issues, and then we have the chance to make them the new basis for the treatment of obesity and type 2 diabetes. If people do not have side effects and if they do respond well. So that's, of course, a prerequisite. So we will always need innovation for new medication because there are sometimes people who do not respond as the average in clinical trials. There's always a need for future research into new medications.
So Matthias, Anette, I hit Matthias there with an unanswered question about, the mechanism of incretin-based therapies. But for you, what are the big unanswered questions in type 1 that you might hope to be solved by 2030?
I think we need more therapies to enhance efficacy. We have one treatment now, and we can, with this treatment, delay the onset by 2 years officially, but there are more data now that suggests it's 3 years. But we have many other treatments where we actually saw also after the onset of diabetes some efficacy on preserving beta cell, on improving glycemic controls that target our immune system. And what is really quite interesting that the targets are quite different. So some of the agents target antigen presentation, T cell stimulation, or they deplete the immune cells, the B cells, the T cells. On some that act actually with cytokines that are important in the. So I think in the future we have the possibility to combine those and when used wisely also to use them in sequence, and that could really enhance hopefully the effect of our delay and prevention. And I think that is the unanswered question. So how much is the delay? How long will be able to sustain the effect in the future, and how can we really combine those different treatments?
Now, diabetes is really having its moment in the sun at the moment. I mean, this is the hottest science congress around at the moment. I mean, as a journalist, I see it in the press. I mean, it's just everything that's going on here in the media worldwide. Do you think that moment in the sun will last? And we have about, I think, the future of the GLP-1. There are 70 other or so medicines in that incretin-based therapies basket that are said to be in the pipeline. Do you think that diabetes moment in the sun will continue?
Yes, I think that, and I really believe it, that we will also have in type 1 diabetes a basket full of different therapies or immune therapies to interfere with the pathogenesis, the disease course, to prevent the disease. And what I also think is very important, what you said, Matthias, is that we need new developments all the time, because we will always have also patients who do not respond to one treatment, and so will probably benefit from new developments as well.
Anything else you want to throw into our 2030 mix?
Just throw in again that primary prevention is also important, and that we know that this autoimmune disease starts very, very early in life, and that we are also very much targeting this early period to try to develop therapies that stop the process from the start. And I think that is also one component maybe in the future.
And how about you, Matthias?
Oh, yeah, primary prevention is also the hot topic for the prevention of type 2 diabetes. Weight loss, healthier body weight, obesity treatment, but also screening of people at risk for metabolic diseases, also cardiometabolic diseases. This is something which is a political task, and we would wish for political support here, of course, for the prevention of type 1 diabetes. That is a super hot topic at this conference particularly, but worldwide, I think. And but also for obesity and type 2 diabetes, because this is sometimes forgotten that it's theoretically a preventable condition.
Fantastic stuff. So interesting. And of course, you can see that on demand at your leisure, and a very good watch it will be. That's all for the moment. Back soon.